Good morning. New week, new topic. This week, our focus would be on patients with the complaint edema. And as always, we would look at the following learning outcomes, define the term edema, look at the various diagnostic triads that are associated with edema, describe the key features of each of the diseases covered in the diagnostic triads, review the labs mentioned during this presentation, and then finally review the significance of the physical signs mentioned directly or indirectly related to the systems in which edema could be originating in. Our index patient is the 71-year-old grandmother of Chloe, Zoe, and Flo. This is Brian's mother, Edna Sicalot. Edna complained suddenly of swelling of her left leg. She had no previous history of trauma, no shortness of breath. We're going to go through what are some possible causes, and at the end, if we have time, we would play the game 20 questions think aloud related to Edna's complaint. Now let's define what edema is. Edema is defined in the dictionary as palpable swelling due to an increase of fluid in the interstitial space and caused by an imbalance in Starling's forces. Now, when we use the term edema, we have to talk about the context. This week we're talking about edema in the clinical context. You may have come across the word edema previously in pathology, and the pathological use of the word edema is different from the clinical use of the word edema. So this is the palpable swelling due to an increased fluid in the interstitial space. From a pathological perspective, it's swelling of tissue due to an increase in the fluid in the interstitial space coming from the intravascular compartment going out into the extravascular compartment. Let's remind you of what Starling's forces are. Starling's forces are forces that are applicable in the terminal end of the arterial system, between the arterial and the venous system. So we're looking at pressures at the capillary level. There is the hydrostatic pressure coming in or related to the heart, pushing blood from the heart to the periphery and then taking blood from the periphery back to the heart. There is the protein gradient that is related to osmotic pressure, which tends to hold water inside the intravascular compartment. There are permeability issues if you have chemicals due to inflammation or other situations that causes not only vasodilation but contraction of the endothelial cells. Then the tissue becomes more permeable to water and fluid coming from the blood outside into the interstitial space. And then the last of the forces would be those related to the lymphatic drainage. So with that said, let's look at the main generators of edema clinically. One is cardiac. Cardiac edema is characterized by bilateral pitting edema. Hepatic edema, in addition to bilateral pitting edema, would be associated primarily with ascites, extra fluid inside the abdominal cavity. Renal edema has a tendency of causing puffiness of both eyelids, which is worse in the morning, better in the evening. Venous edema is characterized by unilateral pitting edema if it's associated with deep vein thrombosis or chronic venous insufficiency or compartment syndrome. And then finally, if this were lymphatic in origin, it would be unilateral, but it would be non-pitting because of the chronic duration of the edema, where the edematous tissue is chronically being infiltrated with fibrous tissue. So this would be non-pitting edema. What about the impact? It's estimated that nearly 2% of the population self-report having edema. This is a little more than 4 million people in the United States on a yearly basis. This is a worrisome complaint. Why? Because it often is a manifestation of serious underlying diseases, either cardiac, renal, hepatic, uh, venous, or lymphatic in origin. And here is something that you need to be aware of. For you to have pitting edema clinically, it will only be evident after more than 2.5 liters of fluid has accumulated. Before that, it is not perceived by palpation. The patient may complain of tightness in their shoes, but it may not present with pitting unless there's more than 2.5 liters of fluid having accumulated in the tissue we're talking about. Any questions? If not, let's look at the first triad, edema associated with pain, and the three conditions we're going to talk about shortly is causing unilateral edema and pain. The first and most common cause of unilateral painful edema is deep vein thrombosis. Deep vein thrombosis is defined as a clot in the deep vein, usually in the leg. It could be caused by one of Virchow's triad factors, which would include vein wall damage, usually traumatic in origin, hypercoagulability, commonly associated in women, on the oral contraception. And if they are not on the oral contraception, the other uncommon cause of hypercoagulability that you must keep in the back of your head are certain cancers like ovarian cancers, stomach cancers, pancreatic cancers. They tend to cause hypercoagulability. And the third is stasis. If you were to sit on an airplane for longer than 4 hours, or in a train or in a bus for longer than 4 hours and not getting up to walk around, or at least flexing and extending your ankles and your calf muscles, then you run the risk of developing a deep vein thrombosis. Regardless of which of the three factors is the trigger for the deep vein thrombosis, the clinical presentation is the same. Sudden onset of leg swelling, so it's unilateral, not bilateral. The swollen leg would be warm and tender, warm, not hot. And I'm making this distinction because there is another disease which will present again sudden onset of swelling of the leg, but in addition to being tender and swollen, the leg is hot, not warm. Homan sign will be positive. We will talk about what Homan sign is later on in the week. Should you suspect a deep vein thrombosis in the primary care setting, your management is to refer to the hospital. While they are there in the hospital in the emergency department, they will order ultrasound venography or plethysmography, looking to document that there is in fact a deep vein thrombosis. And once they have documented this, then they will treat this appropriately. Other lab tests like D-dimer may or may not be done. D-dimer is a good screening test if it is positive because it has a relatively high specificity, but the imaging or test of choice, the gold standard, is ultrasound venography or plethysmography. The next cause of a swelling that of the one limb that is painful is cellulitis. Cellulitis is defined as bacterial infection of the subcutaneous tissue. Causes usually related to contamination of a superficial wound by either Strep pyogenes or Staph aureus bacteria. Gets in through a scratch in the leg or in the arm or forearm, and then it presents with a swelling that is hot and red and tender, and you can see well defined edges. The red part at the bottom you see is just above the ankle. There's no cellulitis of the skin in the foot. And if you follow up the leg, you can see it goes all the way up to where possibly the upper 1/3 meets the middle 1/3, and there's a clear demarcation above that. No cellulitis, the red part cellulitis. Holman's test will be negative. Patients with cellulitis should be referred to urgent care, where the doctor will look at this, possibly do a CBC, looking for an increase in the white blood cell count. And since this is a bacterial infection, then an increase in the neutrophil count. The doctor would then put the patient on a 5-day to 7-day course of antibiotics. An uncommon cause of painful, swollen one limb is complex regional pain syndrome. This is defined as extreme pain following trauma. The trauma could be trivial, trauma to the extremity, or would be obvious trauma like a crush injury. This is more common in females. It's more common in the leg than in the hand. Patients with CRPS, complex regional pain syndrome, will present with a limb that is swollen, it's sweating, and it's very painful. There are two varieties of CRPS, CRPS1 and CRPS2. CRPS1 is usually otherwise known as reflex sympathetic dystrophy, and CRPS2 is called causalgia. It doesn't matter. You are not going to be tested on whether this is CRPS1 or CRPS2 in the boards, and therefore that is not the focus here. You just know that if there is some history of injury, the limb becomes swollen and extremely painful 2 to 3 weeks later. It's not associated with underlying fracture or that sort of stuff, then you're dealing with complex regional pain syndrome. If this has been going on for some time, an x-ray of the affected limb would show osteopenia. So if this is the foot, the osteopenia, otherwise known as localized osteoporosis, is going to affect the tarsal bones primarily. If this were the hand, it would affect the carpal bones primarily. And when that is present, Sudeck's atrophy is part of the diagnosis. So this would be complex regional pain syndrome with Sudeck's atrophy. Co-managed with a pain management specialist, and that could involve chiropractic care, it could involve a medical doctor, it could involve a physiotherapist, it could involve a nutritionist or a neurologist. But if in case you were interested in distinguishing between CRPS1, previously known as reflex sympathetic dystrophy, and CRPS2, causalgia, here are the two of them side by side. CRPS1, they may be a precipitating event. The injury might be trivial. It might have been forgotten. There's no single peripheral nerve involved. There's a physiological change in the affected limb that is going to cause spontaneous pain, swelling of the affected limb, and a difference in the skin temperature. CRPS1 is progressive, and CRPS1 is the one that is associated with bone atrophy, characterized by osteopenia on the X-ray, aka Sudex atrophy. This PowerPoint was taken from this source. And CRPS2, yes, there's going to be an obvious precipitating injury, a severe injury to the limb. Yes, often there's one single peripheral nerve that is involved. No, there's no physiological change in the limb. The patient would just complain of burning pain, allodynia, or hyperalgesia. Allodynia is where a normal, non-painful stimulus is then perceived as painful. So touching the skin, which normally does not cause pain, would be perceived, oh, that's hurting, doc. And hyperalgesia would be an increase in the amount of sensitivity to the pain. Previously, you press them with your fingernail, or you can do that on the unaffected limb, press them with a fingernail. And how is that? That's on a scale of 0 to 10, that's a 1. Same pressure on the affected side, oh, that's a 8. And that is what the difference between hyperalgesia and allodynia. It may or may not be progressive, and when you x-ray the underlying bones in CRPS2, otherwise known as causalgia, it will not show any atrophy. As I said, I am not going to be testing you on whether this is CRPS1 or CRPS2 because that is not the kind of detail, but this is just in case you are looking at trying to differentiate this for your own sake. This is what Sudex atrophy looks like. There is one bone here in which it is more blurred. And could you tell me which foot is it? Is it the one on the left or is it the one on the right? We're looking primarily at the carpal bones, and the carpal bones are kind of washed out, especially the distal part of the tarsal bones here seem to be a little osteoporotic. Thermography. The patient is having problems with the sympathetic tone in the affected foot. The vessels have gone into spasm. The increased sympathetic activity is causing abnormal sweating from that particular limb. And when you use a special imaging called thermography, you can see that the foot on the right, which is the patient's left foot, is vascular. The red areas are good blood supply. And if you look at the right foot of the patient, the left foot in the image, you can see the distal parts of the foot are blue, which means there is less blood going through, less warmth, and therefore it's going to be colder than the other foot. Any questions? If not, let's look at the next triad. The next triad is edema associated with dyspnea, otherwise known as shortness of breath. One is congestive heart failure. There is an asterisk next to that which says we have done this already. And although you have been tested on this already, this does not mean you cannot be tested on this in the next examination. So just to highlight the big things, congestive heart failure is pump failure. The etiology is age related. The older patients, 65 and above, the most common cause is ischemic heart disease. The younger the patient is, and a child or a teenager, is congenital heart disease. A young adult would be valvular heart disease, and an older adult between the ages of 40 and 65 would be a complication of long-standing, not properly treated hypertension. The clinical picture can be separated out into left-sided heart failure versus right-sided heart failure. So I'm going to highlight those that are related to left-sided heart failure, shortness of breath worse than exertion, paroxysmal nocturnal dyspnea, bendopnea, and basal crackles. Those are the ones that are related to left-sided heart failure. Raised jugular venous pressure, a positive hepatojugular reflex, and bilateral ankle edema are features of right-sided heart failure. When they're combined, people tend to use the word congestive heart failure or biventricular failure. Remember, the commonest cause of right heart failure is left heart failure. Should you suspect a patient having congestive heart failure, refer the patient to the hospital and then co-manage with the medical doctor afterwards. The labs that they're going to order in the hospital are your BNP, B-type natriuretic peptide, with a value greater than 400 picograms per deciliter. That is a very good screening tool, but it's not the diagnostic tool. The gold standard for congestive heart failure is the echocardiogram, and you're looking for an ejection systolic fraction less than 40%. Remember, the normal ejection systolic fraction on an echocardiogram is between 55 and 65%. The next cause of edema associated with shortness of breath is chronic bronchitis, one of the two causes of chronic obstructive airway disease. Causes include cigarette smoking, industrial pollution. For you to make the diagnosis of chronic bronchitis, you have to have chronic cough, and chronic cough is defined as, in this particular situation, greater than 3 months and 2 or more consecutive years. In addition to the cough, there will be cyanosis. The cyanosis is central. Remember, in central cyanosis, the lips, the tongue, the fingers, and the toes are blue. And there would be evidence of right-sided heart failure, cor pulmonale, as evidenced by bilateral pitting ankle edema. The x-rays will show increased peribronchial markings. The management is, you have to make a decision. Am I referring this patient to the hospital, or am I referring the patient to a medical doctor or a pulmonologist? If there is fever and or the presence of pulsus paradoxus, and we'll talk about what pulsus paradoxus means at the end of this, because you've done this already. If a fever is present or pulsus paradoxus is present, that's an indication that this patient goes to the hospital, and then they will treat the patient aggressively, find the source of the infection in the lung, treat it, and then discharge the patient either back to the medical doctor or to the pulmonologist. The next cause of edema associated with shortness of breath is wet beriberi. This is a syndrome of signs and symptoms due to the deficiency of thiamine. Remember, thiamine could be dietary lack. It could be associated with chronic alcohol intake. It could be associated with hyperemesis gravidarum, severe vomiting in pregnancy, where the pregnant woman can't hold any of the nutrients going into her system, and she could end up with wet beriberi. The other form of beriberi is dry beriberi, which is peripheral neuropathy and skin rash. In wet beriberi, the classic clinical picture is dyspnea, fatigue, elevated jugular venous pressure, warm, swollen ankles. If you're making notes here, underline the warm, because you can get the same clinical picture of dyspnea, fatigue, elevated jugular venous pressure, swollen legs, and congestive heart failure, which we just reviewed. How do you tell that this congestive heart failure is related to wet beriberi and not congestive heart failure? The extremities in wet beriberi will be warm. I'll explain a little bit about the pathophysiology here. For some inexplicable reason, lack of thiamine in the diet will cause the blood vessels out in the periphery to vasodilate, and the vasodilatation would then increase the vascular permeability. Fluid will then leak out from inside the blood vessel to outside into the interstitial tissue, causing swelling of the legs. But because the blood vessels are dilating, vasodilation, or you may hear it expressed with other teachers, vasodilatation. Uh, the difference between the two words is just where you have been trained originally as a health professional. The English European physicians talk about vasodilatation. Americans tend to talk about vasodilation. It's the same thing. So with the vasodilation or dilatation out in the periphery, the extremities are going to be warm. As opposed to congestive heart failure, the extremities are going to be slightly cooler because of the lack of proper perfusion of blood due to the heart failure. Should you suspect a patient with wet beriberi, refer the patient to the hospital. They would order a vitamin B1 thiamine assay, and if that is confirmatory, they would then give the patient um, an abnormally high amount of B1 in a IV drip over a 24-hour period, and within 48 hours, the patient's deficiency will be corrected and the heart failure presentations would disappear. Any questions? If there are no questions, let's look at another three diseases that are characterized by edema, but this time with fatigue. There are more than 29 causes of fatigue that we will do most of them next week. But right now we're only doing fatigue associated with edema and just three conditions. The first is Cushing's disease or syndrome. There's a difference between the two, which I'll get into reminding you shortly. Cushing's disease stroke syndrome is defined as the condition in which there is excess cortisol in the system. So another word for Cushing's disease or syndrome is hypercortisolism. There are two main causes. It could either be due to a pituitary problem, and that is the one that bears Harvey Cushing's name. That's Cushing's disease. And then if it is due to an adrenal problem or exogenous steroids given by medical doctors, so we're not talking about anabolic steroids that weightlifters may use to bulk up. We're talking about glucocorticoids that medical doctors are going to use for their anti-inflammatory purpose. One is due to an adrenal tumor or exogenous steroids. The name Cushing's syndrome is applied. Now, in pathology, you would have come across two different terms. Cushing's disease in the current pathology books is called ACTH dependent hypercortisolism. And Cushing's syndrome is called ACTH independent hypercortisolism. Boards hasn't gotten around to the new nomenclature, so look out for them wanting you to know what's the difference between Cushing's disease and Cushing's syndrome. Clinical picture for both disease and syndrome, and then I'll give you the one difference that is more common in Cushing's disease and less common in Cushing's syndrome. There's going to be fatigue, there's going to be moon face, there's going to be a buffalo hump, there's going to be obesity, primarily in the truncal region, purple abdominal stria, hypertension, in addition to the edema of the limbs. That is present in both Cushing's disease and syndrome. If you look like in this patient, and I'll show in this region above the upper lip, there's a slight hairiness, and there are a few strands of hair underneath the chin there, then this is called hirsutism. Hirsutism is more likely to be associated with Cushing's disease. And remember, in Cushing's disease, the underlying pathology is there is a benign tumor in the anterior lobe of the pituitary gland that secretes excess ACTH. ACTH stands for adrenocorticotropic hormone. So this hormone stimulates the adrenal cortex. Not all three layers of the adrenal cortex, only the middle and the innermost layer, which are the zona fasciculata, which produces glucocorticoids, and the zona reticularis, which produces androgens. Zona glomerulosa, which produces aldosterone, is not under the control of ACTH. Now, when you have stimulation of the zona reticularis, androgens are produced in excess, and it's the androgens that are going to cause the hirsutism in the female. Management: should you suspect a patient with Cushing's disease or syndrome, you are going to co-manage with an endocrinologist. The endocrinologist is going to order ACTH levels to differentiate between whether this is Cushing's disease or syndrome. In Cushing's disease, ACTH is going to be very high. In Cushing's syndrome, ACTH is going to be low. And then based on the results, is either going to order a CT scan of the head, looking for the enlargement of the cellular tursicus due to the pituitary adenoma, or enlargement of one of the two adrenal glands found on a CT scan of the abdomen. Here is a CT scan of a patient with symptoms of Cushing's disease, and here is the large cellular tursicus right there. Remember that as the cellular tursicus gets larger, it might impinge on the optic chiasma, and then these patients, like with acromegaly, present with problems with vision. They might have bitemporal hemianopia. Here's a patient with Cushing's syndrome. There is a large mass sitting on top of the upper pole on the left kidney. That's a huge adrenal tumor. If you look over on the other side, just underneath the right crus of the diaphragm here, that is the normal size of the right adrenal gland. The right adrenal gland is pyramidal in shape. The left adrenal gland is semilunar in shape. The next cause of edema with fatigue is OSA, obstructive sleep apnea. This is defined as sleep disturbance associated with collapse of the upper airway. This is seen more common in overweight people, more common in men. Classically, would present with fatigue, overweight, excessive daytime somnolence. Somnolence is a big medical word for sleepiness, snoring with spells of apnea, and in men having a neck circumference greater than 17. There is um, a score called the stop bang score, which we will do at some time. For you to make the diagnosis of obstructive sleep apnea, you need to refer the patient to a special sleep lab to have studies done on them to document obstructive sleep apnea. Patients with obstructive sleep apnea should be advised to lose weight. The sleep specialist may then order a CPAP, a continuous positive airway pressure device that they put over their mouth and their nose, and it constantly, while it's on, forces air into the respiratory system and keeps the airway open. Or they may recommend going to see a surgeon who is now trained in installing a particular device underneath the tongue called Inspire, which is going to then contract the muscles that are attached to the hyoid bone, pulls the tongue uh, down, preventing it from blocking the upper airway. This is what the stop bang questionnaire score looks like. You're going to ask the patient to answer the following questions by checking yes or no for each of them. And if there are any of you who think that you could be suffering from obstructive sleep apnea because your partner keeps saying, I'm worried about your snoring, every now and again you would stop snoring. I think, thank goodness, the man is breathing okay, and then all of a sudden you would choke, and then you start back snoring. That's a dangerous sign. So the stop bang is an acronym. S is for snoring, T is for tiredness, O is for observed apnea, P is for high blood pressure, B would be having a BMI greater than 35 kilograms per square meter. The A is for age. Are you older than 50 years? N is for neck circumference. Is it greater than 40 centimeters? And G is for are you a male? And you score 1 point for each positive response. If you have a score between 1 and 2, you are at low risk of suffering from obstructive sleep apnea. If it is between 3 or 4, you are at intermediate risk. And if your score is greater than 5, you're at high risk. But remember what I said originally. If you are going to treat yourself, William Osler says the doctor who treats himself has what? A fool for a patient. So please don't do this on yourself. Do it on your patient. And then there's hypothyroidism. We've covered hypothyroidism previously when we did ear, eye, nose, and throat problem, which was a long while ago. This would have been week 4. So let me remind you, because the fact that we've done this already does not mean you can't be tested on it again. So hypothyroidism, defined obviously as low thyroxine. In the United States, the most common cause of hypothyroidism or mixed edema, which is the name given to hypothyroidism in adults, is Hashimoto's thyroiditis. Uncommonly, it could be a non-secreting pituitary adenoma, which is just occupying space. It's going to press on the thyrotropes, which are the cells specifically in the anterior pituitary lobe that are designed to respond to thyroid stimulating hormone and then produce thyroxine in the thyroid gland. So it will remove the TSH stimulus from the pituitary gland. Patients with hypothyroidism obviously will present with edema, fatigue, constipation, weight loss, hoarse voice, and Waltman sign. The edema here, hence the word edema in mixed edema, is slightly pitting. It is a mixture of water and proteinaceous material of a mixoid pattern, which, and remember, protein tends to hold on to water and therefore will cause pitting edema. This pitting edema can manifest in another way. You might have swelling inside the carpal tunnel, and one of the more common neurological presentations of mixed edema, which is hypothyroidism in the adult, is carpal tunnel syndrome. You do not need to send the patient to a hand surgeon for them to operate. You need to recognize that this could be hypothyroidism by testing the blood, doing a thyroid function panel. You will find that T3 and T4 are low, TSH is going to be high, and you might find antibodies against the thyroglobulin molecules. This is the labs that are necessary to diagnose hypothyroidism in adults and in children. And the management is you co-manage with an endocrinologist. Resist the temptation to put this patient on desiccated thyroid extracts, which could be a good option, but because they're not controlled by the FDA, you don't know which batch is having just the right amount of thyroid extract, because you may have another batch that has too much thyroid extract and you have a third batch that has too little. So my advice as a fellow primary care physician is send the patient off to an endocrinologist who will then determine, is this primary hypothyroidism, meaning the problem is in the thyroid gland, or secondary, it could be arising from a pituitary problem. And in that case, treat the pituitary problem, and hopefully the secondary effect on the thyroid gland would then be removed, and then it would recover. Any questions? If not, let's look at a number of causes of edema that only occur in females. The first is premenstrual edema. This is defined as edema that is worse in the last few days before the onset of menstruation. So we're talking about the females that are in that fertile age period, 14 years to 50 plus. Possible causes are hormonal imbalance, but we don't know exactly what the mechanism is. We have hypotheses, and the hypotheses sound valid until we dig deeper, we do tests, we repeat the research, and then we go, no, it's not due to increase estrogen. How about progesterone? Possible? No. So we actually don't know right now the actual underlying mechanism. Clinical presentation is swelling of both legs. There might be bloating. The patient might complain of feeling bloated, possible weight gain, but then you have to make sure what kind of weight gain. You have to document, have the patient document how much weight have they put on a daily basis in the period coming up to the onset of menstruation, and have them bring that back the next time. No labs are required. Management is to co-manage with a gynecologist. Souza, in his book, recommends giving the patient vitamin D supplements and magnesium. There's been a recent research done on giving the patient sugar pills, in what is known as an open label placebo study. The details of this is in the notes underneath the slide, this particular slide, if you are looking at the regular PowerPoint presentation, because we're not too sure whether vitamin B6 or magnesium, when they work to help reduce the premenstrual edema, whether this is placebo or not. One of the other things that I forgot to mention in the clinical picture is that sometimes premenstrual edema is associated with premenstrual syndrome, which on top of the edema, you have mood swings, and these patients are more prone to accidents. They become more klutzy, closer to their menstrual, their period of menstruation. The second cause of edema in a woman would be edema of pregnancy. This is defined as edema which occurs during pregnancy, and it is related possible to hormones, pressure on the pelvic veins by the growing fetus, or it might be an early presentation of a very serious condition known as preeclampsia. In edema of pregnancy, there will be swelling of both legs. You co-manage with the obstetrician that is dealing with this patient. You refer the patient to the hospital, not back to the obstetrician. I'll tell you why. If the edema is associated with proteinuria and an increase in the blood pressure, the presence of proteinuria and or increase or elevation in the blood pressure makes the diagnosis preeclampsia. Preeclampsia is a serious complication of the second trimester of pregnancy, usually, or early third trimester, and it could easily, within a 24-hour period, go from preeclampsia, which is just edema with proteinuria and elevation of the blood pressure, to the patient flat out having seizures, which is the eclamptic presentation. And then when that happens, that's an emergency situation in which the obstetrician will have to decide, do I sacrifice the baby to save the mother's life, or what if I can't stop the convulsions from happening? So rather than refer the patient back to the obstetrician, because there's no guarantee that that patient will see the obstetrician within the next 24 to 48 hours. You get them to the hospital, let the OBGYN on call make that decision. So if you are treating patients, pregnant patients, in your office as a chiropractor because you are desiring to do that, and I know that some of our graduates in the past have actually gone on and only treating women, and in particular pregnant women. You should have the mechanism to check proteins rapidly in the urine in your office. I mean, you can get these from the nearby pharmacy, 100 dipsticks for, I don't know, $10 or $20, and keep them in your office if you are treating pregnant women in order to identify early stages of preeclampsia of pregnancy. Lipedema is another cause of swelling of the legs in a female. Lipedema is defined as leg swelling due to excess fat. So the edema here in this particular word is a misnomer because it's not fluid, it's actual fat. We don't know what the cause is. We do know that sometimes this runs in the female members of the family. There is none pitting swollen legs, but the feet are not affected. If you look at this patient, her thighs are large, her legs are chunky, but if you look at her feet, the feet are not involved. The swelling is cut off at the bottom there. There's what is known as the cuff sign at the bottom, separating the area where the lipedema is present from the area where there is no increased fat in the subcutaneous tissue in the feet. No labs are necessary. You can make the diagnosis on the physical examination. This should not be confused with lipedema, which we will do later, which tends to occur more so in one limb rather than both limbs. Management: assure the patient that this is not life-threatening. If the patient is concerned about the cosmetic appearances, then the patient could be sent to a surgeon who deals with this disease, either a plastic surgeon or a general surgeon who will have about 2 or 3 different approaches to reduce the amount of fat in the lower limbs. Any questions? If not, let's look at, we can't make the diagnosis on the history, so that's the 80%. We are unable to make the diagnosis on the physical examination, so that's an additional 10%. So we're going to order labs, and we are going to be able to make the diagnosis only in 5% of these patients that that present with edema. And one of the lab findings is low serum albumin. So low albumin in the blood could also be written up as hypoalbuminemia. So we're looking at 3 possible causes of hypoalbuminemia. We're going to find low albumin if we were to order a complete metabolic panel, looking specifically at the total proteins first, and then most labs will then break down the protein into 2 smaller portions, albumin and globulin, and then the third result would be your albumin globulin ratio. So the first cause of hypoalbuminemia is cirrhosis. Cirrhosis is defined as chronic disease of the liver marked by degeneration of cells, inflammation, and fibrous thickening of tissue. Now, if you look at all of that, you can see that from this definition, cirrhosis is a pathological diagnosis. Up to about 15 years ago, in order for a medical doctor or a specialist to confirm the diagnosis of cirrhosis based off of he is an alcoholic, they have swollen legs, ascites, jaundice, anorexia and gynecomastia, and the liver function enzymes are disrupted, they would have to do a liver biopsy. Now, a liver biopsy is not a everyday thing with no complication. This is an invasive technique that is could be complicated by internal hemorrhage. Today, with our sophisticated use of ultrasound and CT scans and AI, we can look at the images, and we would look at that shortly, on an ultrasound or a CT scan and go, yep, this is diagnostic of cirrhosis because I can see these round areas of regeneration. I can see bands of white fibrotic tissue. I can't see inflammation on the CT scan or the ultrasound, but the combination of those findings and others will go, yep, this is typical of cirrhosis. Causes of cirrhosis in America: number 1, alcohol abuse, followed by chronic hepatitis B and C, more C than others. But you should add to this now fatty liver disease. Fatty liver disease is on the rise because of the epidemic of obesity in the American population. It is estimated nearly 40% of all adults in America are meeting the BMI classification criteria for obesity. And therefore, cirrhosis is one of the complications of chronic inflammation caused by excess fat being stored inside the liver cells. As I said previously, the clinical picture: swollen legs, ascites, jaundice, fatigue, anorexia, gynecomastia. These are the big ones I want you to remember. And there's one other, which is palmar erythema. But if you look over on the right side, there are more than 24 plus, maybe 36 manifestations of cirrhosis. Labs that are going to be ordered: you're going to order comprehensive metabolic panel. And if the patient is jaundice, you're also going to order the CBC to tell if there's an underlying viral infection, and you're going to order urinalysis to see if there is excess bilirubin in the urine and if there's absence of urobilinogen in the urine. Primarily, though, you're looking at the comprehensive metabolic panel. You're looking at the bottom half of the results. You're looking specifically at raised bilirubin, raised ALT, raised AST, and if the problem is initiated by alcohol, then your GGT, gamma glutamyl transferase, is going to be markedly elevated. Co-manage with a gastroenterologist. Both of you will have one particular focus, and that focus is to assist the patient to stop drinking. Here is what the CT scan of a patient with marked cirrhosis in the liver. The CT scan of the abdomen is a much better tool. It's highly sensitive and highly specific compared to ultrasound. And you can see from this picture the liver is enlarged. There are areas in which, and I'll show you what these areas are, round areas of, these are macronodules, where you can see these macronodules of areas of hyperplasia of the remaining hepatocytes. The dead hepatocytes are replaced by these bands of fibrotic tissue, and depending on the amount of fibrotic tissue, you can go, this is this grade of cirrhosis using a particular classification. This is what the ultrasound of a similar patient would look like. Again, once you see that curvature there, and you can look and see the layers of the anterior abdominal wall and this wedge-shaped kind of picture, you know this is ultrasound image. And you can see the graininess with the whiter spots. Those are areas with fibrosis, and the grayer spots there, you can see them arranged in nodules. And again, the combination of fibrous tissue and nodules on an ultrasound is diagnostic of cirrhosis. And we don't need any further liver biopsy to then confirm the diagnosis. One of the questionnaires that is useful, because patients who tend to drink too much kind of don't like to admit, I'm not saying they lie, but they are economic with the truth. And the CAGE questionnaire is one good questionnaire to use. CAG is an acronym where the C stands for, and is that a yes or no? Have you ever felt you should cut down on your drinking? Yes, 1. Have people around you annoyed you by criticizing your drinking? Papa, don't you think you should stop drinking so much beer? Yes, another one. Do you feel guilty? The G in the CAGE questionnaire is for guilt about your drinking. Nope, I can handle my drinking. It's not affecting anybody else, so that scores a 0. And E, have you ever had to drink first thing in the morning? The E is for an eye opener. Mm, kind of, yeah, that's a yes. And therefore, my score would be 3 out of 4. And uh, if you scored between 0 and 1, low risk of having a drinking problem. Between 2 and 3, high suspicion of possible alcoholism. If your score is 4, this is virtually diagnostic of alcoholism. Next cause of edema with a low um, albumin in the blood is nephrotic syndrome. Nephrotic syndrome is a chronic disease of the renal basement membrane. Remember the basement membrane, which is sandwiched between the endothelium of the glomerulus and the podocytes in Bowman's capsule in the nephron is destroyed, and therefore loss of the negatively charged basement membrane will allow negatively charged albumin to pass through this porous filter, and then you end up with greater than 3.5 grams of proteins in a 24-hour urine sample. Common causes would include diabetes mellitus, systemic lupus erythematosus, or certain drugs. The clinical picture, whether this is a child or an adult, is more likely to occur in children, and then next likely in younger adults is early morning puffy eyelids, both upper and lower. That is characteristic of renal edema. And then as the disease progresses, the edema will settle out into the feet, the legs, the thigh, and when it gets up above the inguinal ligament, the fluid will be found in excess in the abdominal cavity, and then the patient will present with ascites. You can test for the ascites by doing the test for shifting dullness, which we will talk about towards the end of the week. Management of patients with nephrotic syndrome, you refer the patient to a nephrologist. Now, a nephrologist, if we haven't talked about this before, is a medical doctor who has gone on to study the urinary system and then specializing only in the kidney. He has nothing to do with the ureter. He ignores the bladder completely. You complain of a urethral discharge. He says, sorry, I'm the wrong specialist you're coming to. You need to go back to your medical doctor or go to a urologist. So do not confuse a nephrologist with a urologist. Nephro to do with kidney, urologist to do with the urinary system, which includes the kidney. Labs in a patient with nephrotic syndrome. 1, the diagnosis is characterized by greater than 3.5 grams of protein in a 24-hour urine collection. 2, when you order the comprehensive metabolic panel, you will see a decrease in the amount of proteins, in particular albumin. So you might see these two words, hypoproteinemia. Emia is blood, hypo is low protein, low proteins in the blood, or you may see alternatively hypoalbuminemia. There's an interesting finding in your not your comprehensive metabolic panel, because cholesterol has to be ordered with a different panel. You order a lipid panel. In nephrotic syndrome, cholesterol will be elevated. And this has nothing to do with too much cholesterol in your diet. This has to do with when you lose a fair amount of proteins in your urine, a message goes from the body to the liver to say, could you help replace some of the proteins that are being lost on a daily basis by my kidney? And the liver says, sure, boss, I will help you. And what the liver does, it produces excess amount of lipoproteins, and one of the forms lipoproteins will then become as lipoprotein cholesterol, and therefore there would be excess amount of cholesterol in the blood. Linked with the excess cholesterol in the blood, tiny little droplets of fat are passed through the porous basement membrane and results in oval fat bodies in the urine. And when hundreds upon hundreds of little tiny fat droplets of these oval bodies clump together inside the tubule, they will then form fatty casts. And remember from pathology, fatty casts are pathognomonic, as far as you're concerned, of nephrotic syndrome. So you'll see both the oval bodies and the fatty casts in the urine in a patient with nephrotic syndrome. The third cause of edema associated with hypoalbuminemia is kwashiorkor. Kwashiorkor is a form of malnutrition caused by protein deficiency in the diet. It is seen typically in young children in the tropics, especially the child that has just been weaned off of the breast because mom has delivered another baby and you got to go suck on a bottle with powdered milk for your energy, while the newborn is getting the real deal. In a couple of months, that weaned child is then going to develop edema. The word kwashiorkor is from a Ghanaian word that actually means the displaced one. The child has been displaced from the mother's breast, taken up by the newborn. And so the cause of kwashiorkor is protein deficiency seen commonly in weaned children. The clinical presentation would be swollen arms, abdomen, and legs. That chunky little abdomen there is not fat. That is full of acidic fluid. And they have a drying dermatitis of the skin, usually in the extremities on the forearms and hands, in the legs and the foot. And this dermatitis is classically described as flaky paint dermatitis. The labs that should be ordered would be the comprehensive metabolic panel, which will then show a decrease in the total amount of serum proteins. And when the lab breaks that down, there's going to be a marked reduction in the albumin component of the total protein. So there will be hypoproteinemia associated with hypoalbuminemia, to the point that the normal albumin globulin ratio of 2 to 1 will be reversed. So you can add to this here that another manifestation in the comprehensive metabolic panel is a reversal of your normal albumin globulin ratio. Co-manage with a pediatrician or a nutritionist. Any questions? If there are no further questions, then let's look at the last triad. This is a triad which doesn't fit into any of the clinical triads. We've talked about edema with pain, edema with fatigue, edema with dyspnea, edema with hypoalbuminemia, etc. This doesn't fit into those categories. So what are these three? The first would be chronic venous insufficiency. This may or may not affect both limbs. It could affect one limb more than the other. CVI, chronic venous insufficiency, is a condition characterized by decreased venous return from the legs to the heart. Obesity, varicose veins, or a history of a DVT in one leg are known causes. The clinical picture here is the inverted champagne bottle legs. You can see the patient's left leg is swollen, upper part is swollen, the lower part is narrower, it is darker in color. This gives you the champagne bottle appearance, and then there's a brownish discoloration of the skin, and that skin is hard. So brownish indurated skin. The induration and the brownish discoloration. So the induration is due to chronic edema, and the brownish discoloration of the indurated skin is due to hemosiderin. Hemosiderin is the brown pigment that is released from dead, ruptured red blood cells. And often there might be varicose veins associated more on the side with the chronic venous insufficiency. I said it's often bilateral, but sometimes it could be worse in one leg. Management, if you get this in the early stages, not this late stage, if you get this in the early stage, elevation of the legs, compression stockings on a daily basis might be helpful. If elevation of the legs at the end of a busy day where the leg is higher than the level of the heart, compression stockings don't work, then refer the patient to a vascular surgeon, and they have ways and means of dealing with this. The next cause of a swollen limb, usually again it's unilateral, but sometimes it could be bilateral, is lymphedema. Lymphedema is defined as leg swelling due to blockage of lymph nodes or lymphatic vessels. There are a number of causes. It could be post-surgical lymph node resection for cancer treatment. This patient might have had genital cancer, whether it be cancer of the penis or cancer of the vulva. Part of the treatment is take out the cancerous area and clear out the lymph nodes on the affected area if they are filled with cancer. And then what happens is that you've taken out the lymph nodes, you have blocked the flow of lymphatic fluid from the lower limb back to the abdominal lymph nodes, which are going to drain eventually into the cisternicale and then flow up back into the neck via the thoracic duct. So lymph node clearance for surgery to treat cancer in the area could result in this. Another similar situation is a patient has stage 3 breast cancer. She has the lump removed. She has axillary nodes that are taken away. A couple of months later, the upper limb on that affected side where she had the mastectomy will start to swell up. Or if you lived in the tropics and you were bitten by a mosquito and the mosquito transmitted the microfilaria known as Wuchereria bancrofti, then the picture you see here, which is called elephantiasis, could be one of the causes of lymphedema. Or it could be due to something much rarer, a congenital absence of lymphatic vessels and lymph nodes. This is called Milroy's disease. Milroy's disease has a tendency of affecting one of the 4 extremities. Not all 4 are going to be affected, it's usually one. The clinical picture would be in the beginning, pitting, swelling of the leg and foot, or if it were following mastectomy and axillary node clearance, swelling of the forearm and hand, and then it will become tight and hard, and then eventually you would develop what is known as brawny, spelled B-R-A-W-N-Y, edema. Brawny is another word for tight or indurated swelling. Stemmer sign will be positive. Stemmer sign is the inability, and I'll demonstrate that for you later, the inability to, between your finger and your thumb of your dominant hand, pinch a fold of skin over the base of the dorsum of the second toe in the foot. If you can't do that on the side that is swollen, then stemmer sign is positive, and a positive stemmer sign means the cause of the swelling of the leg is lymphedema. Co-manage with a vascular surgeon. There are a number of advances that have been made in the past 20 years as to how to treat this on-sitely. Often it's not painful. There's a discomfort because there's a heaviness. That particular limb is actually weighing twice the normal weight of the normal limb on the other side. Compression stockings, if you get this in the early stage, could be helpful, along with elevation of the affected leg. If you get this in the early stage, lymphatic massage could be helpful for those of you who come from a massage therapy background. There have been a couple of articles talking about using a particular placement of your kinesio tape to help reduce this edema. The other miscellaneous cause of edema is drug-related edema. Definition, obviously, edema, which is caused by specific drugs. There are three common groups of drugs that can do this. Two underlying mechanisms for these common groups of drugs. One is NSAIDs. Many of your non-steroid or anti-inflammatory agents, specifically ibuprofen and Aleve, will cause sodium retention, and therefore you have to watch how much they use on a daily basis. And the pathophysiological mechanism is that these drugs mess with the sodium excretion from the kidney. More sodium is retained, more water is retained. The hydrostatic pressure within the blood circulatory system is going to be increased, and that increased hydrostatic pressure forces fluid from the intravascular compartment into the interstitial compartment outside the blood vessel. Calcium channel blockers, another group of drugs. These calcium channel blockers are used primarily to treat severe hypertension that is not amenable to diuretics and beta blockers. And the underlying pathophysiology is that if you were to block the calcium effect on blood vessels, you would cause vasodilatation. Vasodilatation increases vascular permeability. You lose fluid from your blood vessel into the interstitial tissue, causing edema. And then the third group, steroid hormones. They act similarly to non-steroid or anti-inflammatory drugs by stimulating the aldosterone receptors in the distal convoluted tubule cells, the principal cells, and this causes sodium retention. Sodium retention causes water retention. Water retention expresses itself in edema. So the clinical picture would be pitting edema, bilateral, following drug administration. No labs are needed. This is a diagnosis that could be made comfortably on the history alone, combined with the fact that you can demonstrate there is pitting edema out in the periphery. Remember, you have to rule out that this is not associated with pain, not associated with shortness of breath, not associated with fatigue, not associated with hypoalbuminemia, etc. None of the other triads that we've talked about. And then you go, okay, now that I've ruled out all of these diseases and you have a history of recently taking one of these groups of drugs, I think this is drug-related edema. I'm going to have to send you back to your primary care physician for possible stopping the drug and replacing it with some other thing that does not cause uh, pitting edema. Any questions? If it's none of the above, then it could be idiopathic edema. Remember, the word idiopathic says we don't know what the cause is. We are idiots about the pathology. We're not saying we're idiots. It's not idiotic edema. It is idiopathic edema. The pathology is unknown to the medical scientists. Idiopathic edema is defined as a syndrome of fluid retention with swelling of the face, hands, trunk, and limbs in the absence of. It's not cardiac, it's not hepatic, it's not renal, it's not nutritional. The cause is unknown. We know that it's only seen in women who menstruate. And it's possible that for some unknown reason, there is increased vascular permeability, but we don't know what triggers this. The clinical picture is swollen arms, face, and legs. There's a cyclical pattern. There is nocturia. They get up at night to pass urine. And if they were documenting their weight on a daily basis, the weight gain should be greater than 3 pounds over a 24-hour period, not over a 72-hour period or a week. This tends to occur closer to the onset of menstruation, so it might be confused with premenstrual edema. And the way you're going to tell the difference is if they have gained more than 3 pounds in a 24-hour period, this is part of the diagnostic criteria for idiopathic edema. Lab tests will be normal, so you have to do your complete blood count. You have to do your comprehensive metabolic panel to rule out electrolyte imbalance or hepatic dysfunction. You have to do your urinalysis to rule out underlying renal pathology. It's a diagnosis by exclusion. Management includes referring to an internist. This is a medical doctor who's gone on to spend another 4 years specialized training in internal medicine. Some research shows that if the patient is put on a low salt diet, it could help in some patients. Avoid the use of thiazide diuretics. And I'm not saying that you guys are going to prescribe or advocate the use of thiazide diuretics. Patients on their own would think, I'm collecting too much fluid. My grandmother is taking water pills for her heart failure. I wonder if I took a couple of her water pills for a couple of days, whether I can't get rid of some of this water. And what happens, for a strange reason, patients who inadvertently take thiazide diuretics, whether officially prescribed or unofficially, the thiazide diuretic will make this edema worse. And if you hear that in the history, that I've taken some diuretics, some water pills to see if I can get rid of some of this water that causes this puffiness in my face and my arms and my legs, and it just made it worse, you go ding, 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 ding. This is idiopathic edema. And you can tell the patient, well, you've had the experience of taking water pills. It didn't work. So I would like to strongly continue to advise you, don't take water pills again because this is going to just make this worse. Any questions? If not, we are going to look at a handful of laboratory test results that we've talked about during this discussion. We talked about ordering a complete blood count. Should the cause of the edema be an infection like cellulitis? Cellulitis was caused or could be caused by a bacterial infection, whether it be Strep pyogenes or Staph aureus. Your complete blood count will show a leukocytosis and neutrophilia. If you had ordered a comprehensive metabolic panel because you had a patient with kwashiorkor, or you suspected the patient having cirrhosis, then total proteins, hypoproteinemia could occur in kwashiorkor. If you thought that this was cirrhosis, the comprehensive metabolic panel would be showing hyperbilirubinemia, increased bilirubin, increased AST, ALT, and as I said before, if this were related to alcohol, then your GGT would also be elevated. If you thought myxedema, hypothyroidism in an adult was the cause of the puffy eyelids, puffy hands, puffy ankles, then the thyroid functions in myxedema will show a decrease in both your T3 and your T4, and concomitantly, because of the negative feedback loop between the thyroid gland and the pituitary gland, your thyroid stimulating hormone TSH would be high. Urinalysis, if there is massive proteinuria, and it would be written as 4 pluses in the lab report, consider the possibility of nephrotic syndrome. If there were excess bilirubin in the urine was kind of darkish green, brownish, then that would be due to excess bilirubin. This bilirubin will be soluble in water. This is why it is showing up in the urine, and then this would be indicative of cirrhosis of the liver. Remember, prehepatic jaundice bilirubin caused by sickle cell disease in a black child, or hereditary spherocytosis in a white child. Uh, Even though the sclera is yellow and the skin is yellow, the urine would be absolutely normal because the bilirubin that is being produced in prehepatic jaundice is unconjugated bilirubin, indirect bilirubin, insoluble in water. Okay. Uh, the other lab that you could have ordered is a urinalysis. If the urinalysis shows oval fat bodies and fatty casts, this would be pathognomonic for nephrotic syndrome. Any questions? Remember, at any time you want to take a break, you can just shut me down, put it on pause, come back later and pick this up where you left off. So let's look at reminding you of some of the signs and tests that you have done already in your physical examination classes. Just bringing this back for purposes of improving your memory, and you're going to get a couple of questions based on a sign or a positive test. What does that mean? The first is the cuff sign. The cuff sign is described as a fold of skin between the bottom of the leg and the ankle. And if this were present, it would look like a tight rubber band around the ankle. The significance of the cuff sign is that the cause of the swollen, in inverted commas, legs and thighs, but not the feet, would be lipedema. Remember, the feet are not involved in this condition. Next is gynecomastia. We talked about gynecomastia as one of the manifestations of cirrhosis of the liver, a cause of edema associated with hypoalbuminemia. Gynecomastia is breast enlargement in the males. This is due to excess estrogens. And I know I'm seeing some of you in the audience going, excess estrogens in males? I thought estrogens are only produced in females. No, males produce estrogen. But the body in the male says, thank you, but I have no need for you. I'm going to pass you through the liver, and my cells in the liver, hepatocytes, are going to remove you out of circulation before you cause problems. However, in a situation like cirrhosis where the hepatocytes are not functioning well, then the liver loses the ability to remove the normally produced estrogen in males, and the estrogen in males then increases in the blood. This is known as hyperestrogenism or hyperestrogenemia. Where there's excess estrogens in the blood, this will then stimulate the rudimentary breast tissue in the males to then develop to form gynecomastia. There are two other situations in which excess estrogen is found. Klinefelter syndrome. This is a genetic condition. Its genotype is 47 chromosomes. The genotype makeup is XXY. The Y is dominant. It will give male characteristics, but the second X is then going to give you secondary female characteristics, including gynecomastia related to hyperestrogenism. And the third cause of hyperestrogenism is an uncommon tumor occurring in the testis, and this is called a Leydig cell tumor. Leydig cell tumors occur in Leydig cells, which normally should produce testosterone. In this abnormal situation where there's a tumor in the Leydig cells, otherwise known as the interstitial cells of Leydig, produce estrogen rather than testosterone. We talked about the hepatojugular reflex as a sign of right heart failure. In this particular reflex, the patient is seated at 45 degrees. You're going to press gently into the right upper quadrant, and if the jugular vein becomes distended while you do this, this is known as the hepatojugular reflex. You press on the liver, the jugular veins in the neck become distended. This is indicative of congested heart failure. The next, remember these are arranged in alphabetical order. So hirsutism follows hepatojugular reflex. Excessive hairiness in females is usually facial hair. Occasionally it might be in the arms and legs, and this is usually due to excess androgens. So if you have a woman suffering from cirrhosis, because cirrhosis and alcoholism and obesity are not limited to men, women can suffer from cirrhosis too. They also produce testosterone in the normal female, where the liver hepatocytes are working well. The excess testosterone goes to the liver. It's removed. In cirrhosis, not removed, and you're going to have hyperandrogenism. In Cushing's disease, not Cushing's syndrome, the excess ACTH, adrenocorticotrophic hormone, not only stimulates the zona fasciculata to produce excess glucocorticoids, it also stimulates the zona reticularis to produce androgens, and androgens in excess will then cause hirsutism in females. And then the last is PCOS, polycystic ovarian syndrome, related to the hyperinsulinism that is going to accompany the overweight scenario that many patients with PCOS, not every patient with PCOS is going to be overweight or suffers from obesity, but they will have hyperinsulinism, which will then trigger excess androgen production in the body. So these are the three situations in which hirsutism may be associated within the clinical scenarios. Holman sign. We talked about Holman sign. Gently squeeze the calf with the knee slightly flexed, or dorsiflex the leg with the knee in the slightly flexed position. The original sign that was described by Dr. Holman more than a century ago was the latter. Slightly flex the knee on the side that you are testing, and then gently dorsiflex the ankle. If either maneuver causes pain in the calf, Holman sign is positive. Holman sign is positive if you have a deep vein thrombosis, or a much less common cause of a positive Holman sign would be a ruptured Baker cyst, and even less common than that is a ruptured plantaris tendon. Both of these will cause inflammation in the deep compartment of the deep part of the posterior compartment of the leg, causing a positive Holman sign. Now, I am sure that some of the older doctors teaching you here might have told you that you should not do a Holman sign, especially if you're going to squeeze the calf, for fear of, if this were a deep vein thrombosis, squeezing the calf might cause a break of a part of the thrombus, and that broken off piece of clot will travel up into the heart, into the lungs, and could kill the patient from pulmonary embolism. That is not true. This has been tested over and over, and has been written up in the literature that doing a Holman's sign or test by squeezing the calf does not induce an embolism to be formed. Then there's palmar erythema. Palmar erythema is the situation obviously affecting the palms of the hand, and erythema is the big medical word for redness. So palmar erythema is defined as the redness of the palmar aspect of both hands, not one hand, both hands. This is caused again by excess estrogen. This is seen commonly in cirrhosis, mainly in men with cirrhosis. Puffy eyelids that are worse in the morning, better in the evening. This is telling you the edema is of renal origin. And the two causes, one we did this week, and the other we will do in a couple of weeks when we do urogenital complaints. So the two causes of puffy eyelids that are worse in the morning, better in the evening, would be nephrotic syndrome and glomerulonephritis. We talked about the presence of purple abdominal stria, classic for Cushing's disease or syndrome. This is due to rapid weight gain, and these are longitudinal stretch marks. Now, there are similar kind of stretch marks that are seen in patients who are pregnant. These stretch marks are less than 1 centimeter in width, and they are not purplish in color. The purple nature of these abdominal stria is due to the rapid tearing of the skin, due to the rapid increase in weight and bleeding into the area where the stria are developing. This is seen in Cushing's disease. And I know that this is disease. This happens to be a female, and you can see the hirsuteness of her anterior abdominal wall. Shifting dullness. We mentioned this when we were talking about the presence of ascites in patients with cirrhosis. In shifting dullness, you're going to place the patient in the supine position facing upwards. You're going to expose the abdomen adequately. You're going to start percussing the abdomen from the umbilicus towards the right flank if you are right-handed and you are standing on the right side of the patient, and you percuss until the hollow percussion note becomes dull. With your percussed finger remaining on that spot, don't take your finger off. Ask the patient to turn away from you and lie on the left side, and then count 10 seconds. And when the 10 seconds are passed, percuss that area that was previously dull. And if it is now hollow, then the dullness has shifted. The presence of shifting dullness, where the percussion note starts off as resonant, it becomes dull because of fluid. And when you turn them away from you and that fluid then settles down towards the bottom of the left side of the abdomen, and air rises up to the top, and that previously dull area, dull, becomes hollow, dull, becomes hollow, then ascites is present. There's another sign that I'm going to mention at this particular time, and I'll tell you why and what to do with this knowledge. It is called the puddle sign. In the puddle sign, you have the patient lie facing down for 5 minutes. The patient then rises on the elbows and knees. You apply the diaphragm of the stethoscope to the most dependent part of the abdomen, which is now the bottom part near the navel, and then you are going to flick, and you are going to flick in the flank with your finger, and you continually to flick in the same spot in the flank. So you're flicking over here, or wherever. You're going to flick one particular part. You're going to move the stethoscope across the abdomen from dependent to the bottom, and you're going to move it up towards the side. And if there was fluid accumulating down at the bottom here, then you would hear the sound of the flicking as dull. And as you move the stethoscope further up from where the fluid is to where there's no fluid, then that flicking sound would increase. The sound transmission does not change when the patient sits. This is a useful sign, they claim, for detecting small amounts of fluid in the abdomen. They claim, this is an article that was published way back in the 1950s. I use the second edition of the Gowan and the Gowan, which is one of the reference texts for general diagnosis. There are 2 or 3 texts for physical examination. This is one of them. The number 1 is the one I've been using most of the times, which is Bates's Guide to Physical Examination and History Taking. This is the number 2, the Gowan and Gowan. I don't have an up-to-date copy. I'm still using the one I used when I started studying medicine in Jamaica in 1969. And on that page, they talk about this particular test. They refer the research, and I've looked, because this is a evidence-based course. I've looked for further examination of this particular sign to see if they can tell me whether this research has been replicated and what's the current sensitivity and specificity. And after about 3 decades, I can't find anything. I can't find anything beyond 1980 something, 1990 something, which actually says this is the sensitivity and specificity of this test, and they confirm that this test is positive for small amounts, less than 125 milliliters of fluid being present. If you were to look in the current Bates Guide to Physical Examination and History Taking, it is not in there. They have dropped this for the longest while. It's not there in Seidel. It's not there in Schwartz and under the other um, uh, reference texts. This is of historical significance only. However, I was asked 5 years ago, because I always ask my students after the exam, if you have been asked any strange question about general diagnosis in part 2 that you've never heard about, make a note of this, and once you come back on campus, drop me a note. And a couple of students wrote to me asking, what is the puddle sign? And I'm going, I didn't really learn about the puddle sign recently. I remembered reading about it years ago, dug up the reference, passed this on to him or her, and that's the only reason I'm including this in this discussion. Should you get a question in Boards Part 2, General Diagnosis, a positive puddle sign is indicative of which of the following, and they gave you 4 choices. Look for ascites. Puddle sign is not present in intestinal obstruction, generalized peritonitis, ruptured appendicitis, or any of those things. It is a test for ascites that is seen commonly in cirrhosis. But as I said, it's only of historical significance. Here's your stemmer sign. Attempt to pinch the skin over the dorsum of the proximal part of the second toe. Inability to do so because of the thickness of the skin constitutes a positive stemmer sign. This is seen in lymphedema. It has a relatively high sensitivity, 92%, but a specificity is not all that present. So remember the usefulness of a test that is highly sensitive. You can only use the test if this highly sensitive test's result is negative. Remember, the mnemonic is SNOUT. SN for sensitivity, N for negative result, OUT. Let me repeat that again. If a highly sensitive test result is negative, you can comfortably rule out the presence of this particular disease. Any questions? All right, that's the end of this week's presentation. In preparation for next week, we'll be doing fatigue. I need you to download the appropriate keywords, read the chapter, look over the keywords. As I said, you will recognize 50 to 60% of the information because you've done this already. This course is bringing all of that together, presenting it in a slightly different manner, in a way that is going to help you in the future to make right diagnoses. Okay.